My name is J.D. Newsom. I'm the Executive Director with the Big Bend Regional Hospital District. And I think it would be helpful to explain a little bit about what the hospital district is and isn't, because I don't think many people really understand what we do. And if you're a property owner, you probably see that line on your property tax statement. It says the hospital district. The hospital district is funded out of property taxes. And the state constitution says that counties have a responsibility to take care of their indigent population's medical care. And counties can do that in two ways. One, they can do it themselves, or a hospital district can be formed and take that responsibility from the county. And the Big Bend Regional Hospital District was formed when, and we're a unique hospital district because we cover two counties, when the Presidio Hospital District, the Presidio County Hospital District, and the Brewster County Hospital District merged. This was done in the early 90s, and that was through an act of legislation that was spearheaded by Pete Gallego. And the idea then, and the idea still, I think, is the two counties are better together in terms of pooling resources and helping to provide for that indigent health care for both counties. Our program, and indigent is really just we help the neediest county residents, and we've got programs that help folks cover their medical bills, both emergency and preventative. We just added dental and vision to help with some of those issues. And we also cover prescription medications, and we've got a special program for seniors that if you're on Medicare but not Part D, we can help if you qualify income and resource-wise. We'll help provide those medications. So our primary focus is providing that indigent medical care, but hospital districts are also charged with ensuring access to medical care for all county residents. So that's where the hospital district has some responsibility and I think some duties to look at issues around access to medical care. Most hospital districts, or many hospital districts, and they come in many different shapes and sizes throughout the state, oftentimes will run the county hospital. We don't have a county hospital because in 1999, the hospital district entered into a development agreement with what is now Quorum Healthcare to build and operate the hospital that sits here in Alpine. And a hospital is very, very expensive to build. You're looking at, we just did a feasibility study for building a hospital in the city of Presidio, and a micro hospital today would cost about $14 million to build. So it's very, very expensive. And I wasn't here in 1999, but I suspect that at the time that it was probably a better value and a better deal to enter into the development agreement with a for-profit corporation to run the hospital here. The hospital district does own the land that the hospital sits on, but the hospital owns the building and all the equipment and everything else, and they are pretty autonomous and have basically pretty independently run that hospital. What am I missing? That's the hospital district in a nutshell. I think for us the challenge is, Alpine, because the hospital's in Alpine, we've got the most resources out of all the communities that we work in throughout Brewster and Presidio County. But we look at Terlingua, which has zero access or zero healthcare resources apart from some emergency services. The city of Presidio is also pretty difficult because there is a clinic there, but there is no after-hours care. So it's very difficult for the residents in our outlying communities to access health care that we appreciate having here in Alpine. So we're definitely looking at some of those things, and just completed a huge grant you guys may have been reading about recently in the paper. It was a USDA grant to build a consortium of healthcare providers to look at this topic of how to increase access to healthcare in our region. And it's a pretty complicated, a lot of complicated issues to work through. But I think what I would like to see the hospital district do better at is looking for opportunities like this USDA grant we just applied for to leverage our community resources to bring in more federal dollars and resources to help us with all of the issues that we have around rural healthcare.
Real quick, I heard that Alpine residents have life flight services included in their tax bill. Is that correct? You know?
So my understanding, that was a service that the city of Alpine negotiated with, not AeroCare, but AeroCare just merged with First Flight, right? And I think when that merger happened, the city of Alpine decided not to proceed with that. But that was between the city and First Flight, so I don't really know a lot of the details on that.
Okay.
Are you considering including Marathon in your remote areas?
So we service, Marathon's part of our service area, and we certainly help a lot of folks in Marathon. But again,
we have a clinic.
You've got a clinic, but it's
nothing
right.
functioning.
And of course, we're looking at, I shouldn't have left Marathon out, but that's another community with very few healthcare resources as well. So, and including emergency services, and that's something that we talk about a lot. So, you know.
I'm Adrian Billings. I'm a family physician, and I'm in my 15th year of practicing out here. And I'm going to start with a quote that is really important to me, and my kids get tired of me saying it to them over and over again. But I think it really speaks to the importance of what JD was just talking about, and that's a team, a consortium that he was discussing. This quote that I love is from Dr. Paul Farmer. As a medical student, Paul Farmer at Harvard was a medical student and created an organization that's now in its 20th or 30th year called Partners in Health. And it does a lot of access to care issues around the world, including in our own country on many of our Native American reservations where there's difficulty accessing care. The quote goes, "Our most significant accomplishments in life will be done in partnership as a team." At this time during this pandemic, even before the pandemic, we provide healthcare as a team. It's not just a doctor, it's not just a nurse, it's not just an administrator, it's a team. To provide the best care out there, we have to have a team. And if we don't have that, then we don't provide as good a care as we need to be doing. Rural healthcare teams are like small football teams. We have very few people on the bench, if anybody on the bench. If any of you live streamed or went to the Alpine Tornillo football game last night, Tornillo had a really small football team, had about 3 kids on the bench. And they had, some kids got hurt during the game, and then they had 0 people on the bench. And I use that as an analogy. That is the majority of most rural healthcare teams. They're just very, very small and very, very busy. And when somebody gets sick, or somebody leaves, or somebody retires, there's nobody to pull from. And there's not a large group of healthcare providers that are interested in rural medicine for all of the challenges and the access to care issues that there are. So I'm going to tell you a little bit about my story because it's going to talk about several federal programs that enabled me to come out here, have enabled me to stay, that I think are very, very important for medically underserved areas. So how did I get here? Well, I grew up a couple of hours down the road driving in Del Rio. And I had this amazing community doctor that delivered me in Del Rio and took care of me really into college when I'd come back home and need something. And he was the reason, he was my mentor before I knew what a mentor was. And he was the community doctor that I wanted to become because he printed his home telephone number in the phone book. I was able to call him on a Saturday afternoon when I had a rabies exposure and my parents and I thought I was about to die. He was on the high school Friday night on the sidelines, walking, looking at the kids, and he was just a role model. And he was a family doctor, but really he was a community physician. And so that's what I've aspired to try and become, is to try and become like Dr. Garcia is his name. Trying to meet the needs of my community, sometimes whether I want to, whether I don't, it's just because the need is there, and service has been very important to me. So I went to medical school on a federal scholarship called the National Health Service Corps. And that's a federal program that's actually in its 50th year right now. And it was created back with legislation in 1970, signed by Richard Nixon, and it put 181 physicians in mainly rural, medically underserved areas, and mainly in the South. Now, 50 years later, it has grown to not just physicians, but it has that team that I just discussed. It has social workers, pharmacists, nurses, the whole gamut of the healthcare professional team that we need. And so now it is 16,000. It has grown from 181 members in 1972, which were the first clinicians in the field, to now 16,000. But I went to medical school on a scholarship. So you as a taxpayer, I imagine each of you were paying taxes in 1999 to 2003 when I was in medical school. So thank you. You paid for my medical school, and you gave me a small living stipend to live on. My repayment was to come practice in a medically underserved area of my choosing for 4 years. And why did I choose Alpine? Well, I tried to choose Del Rio, but amazingly back then it was not underserved enough. Unfortunately, it is now. It would qualify now if I was graduating from residency, but it was not then. However, I came out here as a medical student in 2000, the summer of 2000, and the hospital district paid for my housing out here. I had an amazing experience. They treated me like a resident. I was able to help deliver babies, scrub on surgeries, and remove the end of an amputated finger, and I just had a resident experience out here. Importantly, I began to plant roots. I began to see the need. I began to see the true potential of family medicine, and I began to see community medicine being practiced by going with Dr. Lukey in the community and having him, give diagnoses or give consent or give advice in the grocery store or at church. I came out again 2 years later as a medical student again. Hospital district again funded my housing here, so I didn't have to pay for 2 places in Galveston where I was in medical school, and then also here in Alpine. And again, the roots were being planted as a medical student. Then I went into residency, and I came out again for a 3rd month. And this time the hospital paid for my housing, so I didn't have to continue paying my housing additionally in Fort Worth, where I was doing my residency. But I really came out, and it was really before I decided to come here and practice for sure. And I came out for the month, and I felt this is where I'm feeling called to be. And so I let the federal government know, and the Brewster County had a high enough health professional shortage area score that I could fulfill my 4-year obligation here in Brewster County. And when I came out as a National Health Service Corps scholar, I had to function as a federally qualified health center. So that's the other big program that I want to talk to you about, the federally qualified health center program. So when I came out here, there was not a federally qualified health center in Alpine. There was in Marfa and Presidio. They were just beginning. Presidio County Health Services is what they were called then. But I wanted to live in Alpine because I knew I needed to live close to the hospital because I was going to be doing hospital medicine and also delivering babies. And I didn't want to be commuting from Marfa. So I functioned as a private practice as a federally qualified health center, meaning I didn't turn anybody away. I saw everybody whether they had insurance or whether they didn't. And if they didn't have insurance, I could charge them, but I couldn't, many times they couldn't pay. And that was okay. When they couldn't pay, I just saw somebody else who could to help support and sustain my practice. But at the end of my 4 years, and I had to see Medicare and Medicaid, I couldn't turn anybody away, essentially. That's kind of what a federally qualified health center. But after 4 years of being on call 24 hours a day, 7 days a week, and it being really difficult to get out of town, I knew I needed to do something different. And I started to think about my impact, and I'm still thinking 15 years later now about my impact as a physician. And my solo private practice, functioning as a community health center without the benefits of a federally qualified health center, which are grant support for indigent healthcare, as well as malpractice that's covered by the federal government, I didn't have that. And I had one nurse practitioner as me, and there was one location, it was Alpine. I couldn't recruit a partner to join me. Nobody wanted to come join me in a rural private practice. And so I knew I needed to do something different. I thought about moving, and my wife said, no, we're not moving. And so I knew I needed to do something more impactful that would be more impactful for the community, and then also help me personally by being able to recruit a partner. So that's 10 years ago, I joined Presidio County Health Services, which is now Preventative Care Health Services. So they are a federally qualified health center. So let me tell you about the impact of a federally qualified health center. FQHCs is the acronym. They are all nonprofits, and there's about 3,000 of them throughout the United States. They were also created about the same time that the National Health Service Corps was created in the 1970s to be safety net clinics for underserved populations, whether they be rural or whether they be urban. So all FQHCs are nonprofit. They are all governed by a volunteer board of directors, of which 51% of them have to be patients of the health center, so they know what it's like to access healthcare within the center. All FQHCs receive free federal malpractice covered by the federal government. Now, it's free, but it comes with a big hook. We have to do quality measures that we have to report every year to the federal government. How well our diabetics are controlled, if all of our asthmatics are on, our most severe asthmatics are on inhaled steroids daily. Lots of different quality measures that are really important at looking at population health and taking care of a community and a population. All FQHCs also, this is significant, receive federal tax dollars in the form of a 330B grant to take care of the indigent healthcare in the communities that they serve. So we also cannot turn away patients. We cannot exclude Medicare or Medicaid. And if you come to see us and you're 200% or more above the federal poverty level with no insurance, your office visit is $25. That does not come anywhere near covering our overhead. But that's where that 330B grant, those tax dollars that are returning to Presidio and Brewster County, that's where those tax dollars come in to help support that indigent healthcare. Also, now we are 3 locations, Alpine, Marfa, and Presidio. We started out just me and a nurse practitioner and a former medical student who came back to join me. And now we are, one of our doctors, Dr. Simmons, is here, the first ever nephrologist that's ever been out in the Big Bend as far as I know. So we now have 5 physicians working with us. We now have 3 dentists working with us. We have several part-time licensed professional counselors. And so when I think of the impact of my small private practice at the Pierce Clinic years and years ago to now, 3 locations, a nonprofit, we're receiving about $2 million a year in federal grant support from the 330B program. We have dental care, we have behavioral health care. We started a pharmacy down in Presidio. We opened that up about 3 or 4 months ago. We have a pharmacist working there now. We coordinate a rural residency program here with Texas Tech Permian Basin. And when I think of that footprint now and the impact on the community, it's much more significant now than it was in my solo private practice. And it gets back to that team model, right? That quote that I gave, that really if we're not working together, we're not going to have as much of an impact together compared to being alone. And so I've kind of rambled a little bit, but it's really talking about teamwork, and that's really needed. And so I'm really excited that we are in this consortium with the hospital district and with others trying to impact rural healthcare, because healthcare, especially rural healthcare, this is a really difficult time. We're hanging on by a thread, and at times we feel like we cannot meet the standard of care when we don't have all the resources that we need. And if we're not pulling together collectively as a team, then ultimately the patient is going to suffer. And so I'm really excited about this USDA grant and the possibilities of that.
Okay. So now what I'd like for you to do is to kind of summarize the issues in your individual groups. not necessarily to say everything, like this person said this person said this, but just to give us the summary of it. If you had any things that everybody experiences, everybody shared, or if there was something new or surprising in your particular discussion, then share that. So I'm assuming you all have a reporter. Is there somebody who wants to start? You can start. And if you can use the microphone, that will help.
Okay. I'll start. One of the main things which kind of, I guess, encompassed a lot of the issues that we talked about was to have a clearinghouse or something like that where you can find out information. Is there a central source for finding information on doctors, where you get blood work, where you get emergency care, where you get emergency transportation, including just, or even transportation for medical needs if you can't drive for some reason? How do you get to El Paso? How do you get to Odessa? That kind of thing, and or where would you get dialysis? What are the pharmacies locally? What do each of them provide? Do they provide any different services at different pharmacies? And that information doesn't appear to be centralized anyway. And the experience of the people in our group, and it would be very useful, I think, if there was someone who put together that kind of information and it was available through the city or even through the hospital or the medical center. So that was kind of it covered a lot of issues then. Then the other was, which part of it was, if you have a serious illness, do you need to provide your own transportation? Like, do you need to have the insurance for care flights? Do you need to have insurance that covers ambulances or whatever would take you to where you can get the care? And does insurance pay that? The next one was, how do we go about luring medical care personnel through the Alpine? What can we do as individuals to increase the number of the medical care that's available? And how can individuals help that happen, make that happen? And the last one was, apparently there are specialists for various kinds of medical issues that come to Alpine every once in a while, but there doesn't appear to be any schedule on anyone that really knows when they come, how long they stay, and who they see. So is there a way to find that out also?
My name is Angie McGuire. I'm the Instructional Technology Coordinator at Sul Ross State University for the Department of Nursing. And yes, we are here. That's what I always get that question. We have one of our nurse educators here, Dr. Benita Smith as well. And we're very just excited to be here today. In our group, overall, the theme was critical care for our special populations, including our geriatric ages, and what to do for those particular populations when they need care. How do they access that care? Where do they go? So the information itself, getting that out there seemed to be a really big issue, and then just access to it in our neighboring communities where there is nothing. And how they're not educated, they don't know, and I'm an educator, so that's kind of like where I'm coming with this. How do they know? And so I love what our former speaker, what you said, that's a wonderful idea. How do we know where to get that? So the specialized care and the assisted living. What about home health? How are these things being organized in our communities, especially outside of just the city limits of Alpine, obviously inside, but 30 miles away. If you're hearing on the phone, I heard that. Oh, I heard that they had that available, but then, you call to get accessible services and, oh, no, we don't serve that area. Well, my goodness. Yeah, that's a problem, I think. We were concerned about that. So obviously lives are at risk here. And that I think it's scary. And we can't get people in. This is another thing where we're having trouble getting people in who are specialized or may be looking to, get practice and start a practice like Dr. Billings, and yet it's just not alluring to them. So there's not a catch, I guess. These these young physicians who we have available, these young specialists, or I say young because I'm not young anymore, but they're not wanting, they don't see the benefit for themselves and their families, which, you know, all lives matter. And of course, you know, if you're starting a family, you want to think about your children. So that was an overall theme of where we were, what we were discussing. So I think overall, we also we're worried about the funding and, you know, who is in charge of the economic growth of these areas and how is that benefiting our healthcare and how is that working to draw people in. And I'll just say the organization of it just seems that there's a lack of communication, there's a lack of organization. Who's going to take the spearhead? You know, who's going to lead that? And so I think, you know, whoever it is, whatever comes out of these meetings, and whatever it is that we're solutions that we're providing, that it needs to be people, and we all, I think, can agree if you've been here for a while, and I have not, but this is a community who you have to want to be here. And if you're going to be here, you want to be leading. You know, we need good leaders who want to be here and have the best interests of the community at heart. And so I think that was everything we really wanted to talk about. And thank you so much. I'm happy to be here, definitely. And the Department of Nursing here at Sul Ross University. I know it's been kind of tricky over the last few years with the been in and out rumors and everything, but we are rocking and rolling and we're moving. And we've got some wonderful nurses coming your way. Rural nurses, nurses who live here.
Okay, I'm Benita Smith, and I am with the Sul Ross Nursing Program. I'm one of the faculty there. And our conversation, I had Kathy Donnell, Dennis Foley, Edie Simmons, and J.D. Newsom in our group. And I'm here on a twofold thing, and I'm having a low sugar thing right now. That's why I'm shaking like an idiot. Okay, so I'm here twofold. I live in Terlingua, and I see the lack of health care down in Terlingua. Moved here 5 years ago to Terlingua. One thing that came out was growing our own, trying to interest our high school students in taking advantage of the program that will pay for their education and then get them back here to this area. So that's something that came up as a discussion in our area. Also, the rural health hospital closures came up, the L&D diversions that have happened recently, all of those things came up into our conversation. Lack of some of the specialties like long-term care, hospice care, home health, especially if you live out of the Alpine area, that's not down in Terlingua. I've personally seen a couple people pass from cancer without hospice care. Rehab care, I've seen that. You know, my husband had to do rehab in a nursing home in Fort Stockton after a fall, so I've seen all of those things happen. We also talked about the prevention and education prevention that could maybe forestall some of the need for specialist and specialist care. I've seen that happening, and that was a discussion that came up in our area. And then also there's very positive about the idea that it is more personalized care that you see in our community because our physicians and healthcare people are parts of the community, and specialized care, you might be the only person having a baby in labor and delivery that night, and the specialized care that you get because of being that only person. And the idea that it may take weeks to get in to see the specialist that you need, or even the family practice doctor, because of the lack of healthcare in the area.
I'm Martha Latta, and after the 4 people in our group told their stories, there were 2 common themes that came out as problems. And one was ambulance issues. Between, at one time we had an ambulance service that was run by people not from Alpine, not from the area. So they were unfamiliar with the region and didn't know how to get places, and in one instance even had to be told how to get to the hospital when the train blocks the way. That's pretty bad. Another instance was an ambulance driver refusing to disclose the name of the person that they had been sent to pick up because it violated HIPAA rules, and they just needed to go to an address. Well, all of us that live like south of town in Double Diamond Do you know the numbers of every house? No, but you know who lives there, right? So that's very frustrating. And then the questionable services, other than getting you from point A to point B, that are available on our current ambulance system. I mean, can they provide any care, or do they just transport? That's something you kind of don't want to find out when you're the person on the gurney. The other issue that was common amongst us was the fact that at the hospital, the emergency room is oftentimes staffed by visiting physicians from out of town. And so that again leads to this, the doctor not knowing who you are, who your clan is, where you belong, who to get in touch with, that kind of thing. And I guess when they're operating in a big city, that's the status quo. But one of the reasons that we all love Alpine is because we have a community here. We all know each other. We all have each other's backs. So if you have to go to the emergency room and you're just sort of treated like a number or an unknown, that's kind of disconcerting, and it can take longer to get the necessary consents and that kind of thing if they don't know who you are and how to get hold of who can make decisions for you. So most of our stories fell into those two categories.
What we should do now is to look for some kind of common issues that we see. To see if there's what things we share, what things we found surprising, or something that we really had not thought about before, any of those kinds of things. So if you just scroll down, so there's, this is a kind of a little bit of a solution, I guess, just comes naturally out of issues of not knowing where the resources are. And I understand that some of you are new in that group, you're new to the area. Okay, so that makes it even. Yeah.
Is it possible to ask a question related to this first group, which I was in? I was wanting to ask the doctor. You described the progress made from you and one helper across 15 or 20 years, and we're there. And he had a quote, he had a quote and said, Alpine is a wonderful place to retire, but a hard place to grow old, which is sort of what you said. So that the grant money that you talked about is wonderful for the indigent that it provides services. To my mind, people that are out there growing old, they need specialists. And I don't know that we'll ever have a town full of specialists. Can there not be shuttles, or can there not be some way so that people don't drop everything and need their friends to drive to El Paso? Those are like, does that qualify for grant, or is that just the wrong road?
No, that's absolutely right. There is one program that maybe everybody's not aware of. It's called TRACS. And it's a nonprofit big game community action. And my understanding, many of our patients use them. They provide either no cost if you have Medicaid, and very reasonable cost if you have Medicare or you just need a ride, either within the Big Bend area or to specialists in Fort Stockton, Midland, Odessa, and I think even El Paso and maybe San Angelo. So TRAX, T-R-A-X-X, Big Bend Community Action, they have locations, at least I know of, in Presidio, Marfa, and Alpine. I'm not sure about Terlingua if they're in South County, but that is one resource where you can get kind of a taxi ride. No, it is.
And that's the kind of thing that we're talking about, that we don't know, we can't find that stuff, we don't know. So that would be to put in there too, thank you.
I'll just add, if there is a silver lining to this pandemic, it's telehealth.
Yes.
And although telehealth is not as great as sitting in front of your provider and being examined by them and being able to talk to them, that has really been enabled as a result of this pandemic. And I think that this is going to just go forward. So I think that it's going to, has, and I think it will continue to expand access to care, especially for really disparate populations like ours, being able to access where, yeah, we're never gonna be able to support a full-time cardiologist here or a full-time pediatric orthopedic surgeon, but maybe there can at least be some sort of access to care via an individual monitor.
I wish you would add that to our notes. That's a plus that needs to be marketed so that we have a lot of that. Thank you.
And is it true that there are specialists that come on a regular basis that maybe if they were word out somehow that, or in, we talked about having a liaison or something, somebody we could communicate with to find out.
Yeah, that is interesting to me, from a physician, because of course I don't know exactly when they're coming, but I know who comes. But I think for the lay public, yeah, you don't know if you're not having to access them or suddenly you need to. And I think that's a really great idea, trying to put together some sort of community pamphlet or booklet of, who are the healthcare providers in the area, who comes, 2 cardiologists come twice a month, an orthopedic surgeon comes once or twice a month as well. A neurologist comes, a group actually comes from El Paso, they come quarterly out here. Those are the specialists that I'm aware of, and then of course we have Dr. Simmons, the nephrologist, who's here full-time, living
And
here.
audiologist comes twice a month.
That's right.
So I am working on a book. Part of my strategic plan this year is to put together a book, and I'm gonna try to sell advertising in it, have it printed, and if I can get enough advertising dollars, I'll put it in everybody's mailbox in the tri-counties, but.
But also on the web.
Well, yeah,
I was gonna say-
Updates all the time.
I hear what you're saying is that not only does it need to be, about, and I don't know what exactly you're putting in here, but it needs to be a free resource. I'm an educator, and so I'm not trying to take away what you're doing, but a website can easily be built. I was just thinking that's intelligent, Dr. Smith here, that's a great project. I've certainly built websites before, so a project for our students because part of this program that we have at SRSU is designed, the framework is rural and border community health. So in all of their studies, there is a tie to that. And so developing a website for the community or having the community involved with us so that we can collaboratively do that, because that's the best way to get information and get that out there. Certainly incorporate on a website, put it in a bulletin or a brochure, put it in the paper.
And refer to it.
Yes, it's called this. This is what it's called.
Here's a comment.
I don't know where I got it, but Community Action, the people who also handle the transportation of tracks, they put out a booklet a few years ago that did give a lot of information. And I don't know if they do this on a regular basis or not, but perhaps a coordination of 2 or 3 groups could get such a book out. Again, I don't even know where I got it, but it's the sort of thing that certainly we could come up with a way of distributing it to the wider community.
I used to work at an organization that helped people find resources. And so we put together booklets, and those were helpful, and also websites listed in the booklets.
With the links to the certain areas and the phone numbers.
So, we would try to update it every couple of years, but things often change pretty quickly. So having it on both, you could have that booklet.
Just remember that half of our county residents don't speak English.
That's right.
And a good portion don't have computer or internet, so
It has to be paper as well.
it has to be paper.
Yes.
If you're doing it on paper, putting it on the web is piece of cake.
And we can have everything translated. I've worked with bilingual education for 20 years, and that's not a hard thing to do. And yes, for our indigenous, our underrepresented minorities and our not native English speakers, that's an excellent idea. And then I want to address that things change. Dr. Billings and Mr. Newsom, I'm sorry. Things change so rapidly here. In my year and a half of living here, which I absolutely love the community, I'm vested in this community, this is wonderful. But it has changed so much. I'm trying to keep up with it at the Department of Nursing as we're getting our feet off the ground. It's been very taxing and very hard for us to do. So yeah, updates.
I think that this is a place for the library actually to help disseminate that information.
It could be a good drop-off point, and we could attach the websites or however the information is getting out as a resource.
And the tourist office, I mean, there's a new person, that's one of the places I went, and there was a lot of stuff that they didn't have that kind of information, and having a pamphlet that you could have there, and they would have a list of websites too, so.
She also mentioned, it's the county and the city ought to care because someone that is trying to move here needs dialysis, and she's figured out there's not any here, and so she found out, okay, Fort Stockton's over here. She called them, they're full, or, she won't move here if she can't. People need this information.
Well, the first place that I called or looked at on the web when I was, trying to get here, was the city. And there was hardly anything, so yeah.
One kind of common theme that runs through all of this is a lack of economic resources. And I think we need to expect more of our political representation at the state and the national level. Just to give you an example, recently there was a disaster declared on the border, and money was distributed by the state out to what? The police forces that were in the counties. And when I heard that, I was going, but that's not where the need is. The need is in healthcare. And so I think we need to demand more attention. I particularly think that the federal government is probably a better source because they've got more money than the state has, but there needs to be some understanding, especially at the state level, that rural health care has been totally neglected financially. And we have a much worse disaster regarding COVID, regarding healthcare in general in rural areas than everything that was going on at the border. And we have to demand that be provided by our elected representatives. So that's my soapbox.
And to speak to that, 2 Mondays ago, the Texas House Public Health Committee convened as part of the interim session, the second or third interim session that they're in. And it was specifically on Texas-Mexico border healthcare issues. And so there were 8 witnesses. I was fortunate to be asked to come and tell our story of our labor and delivery nursing workforce shortage, and so I spoke of our need and our lack of healthcare workforce here, and how since February of 2021 we've lost 5 physicians in the Big Bend area, 2 advanced practice clinicians. As of November 4th, there will be 3rd, so 8 total clinicians in this area, which represents more than 50% of our healthcare provider workforce out here. But I love this theme of growing our own, because what I proposed to them was based on a University of Illinois Rockford College of Medicine program that's been supported by the state legislature of growing their own rural students into becoming rural nurses, rural physicians, and rural pharmacists, soon to be expanded to social worker, dentistry, and public health. I advocated, because this does not exist right now, a Texas Center for Rural Health Education, where if you're a rural kid and you want to go into healthcare, or if you're an urban kid that just wants to do rural healthcare when they finish their training, you get priority admission into our publicly funded healthcare training schools, whether that be Sol Ross, whether that be medical school or social worker school. And because the state is sitting on billions of ARPA funds right now, American Rescue Plan Act funds, that they're trying to find pet projects for. And so I was very pleased. They kept me up there. I had 10 minutes to speak, and I spoke for 9. And then they kept me up there 20 minutes asking me questions, and most of the witnesses after me referenced me. So I'm hopeful, but I'm also realistic. At least we had a seat at the table at the Public Health Committee several weeks ago, and they've heard our story, and they know how to get in touch with us.
And so the grant money, that's obviously federal grant money that they're getting, and I know that we're really concerned here at the Department of Nursing how we can get funds funneled through our department that obviously benefit the community. We have a great need to have our students in a clinical experience out in the community, and we're struggling with that because of a few reasons, and we're working through all of that. But I think looking at those federal grants for things like that would be excellent. And it's really hard to find and dig through all the grant opportunities. If you've ever gotten into grant writing at all, it's very difficult to like pinpoint what's going to be good. So good for you.
And I think, the grant that the hospital district is
Yeah.
coordinating, U.S. Department of Agriculture for federal grants.
Yes.
And I think, again, this consortium, of Sol Ross, the nonprofit health organizations that are out here in the hospital district, I mean, we've got to do more, and we've got to be looking for grants. We don't have all the resources, nor all the knowledge, nor all the help to solve our own problems. We have to be collaborating with Texas Tech El Paso, with Texas Tech Permian Basin, anybody who has an interest. And there's lots of these rural training institutions that are very much interested in rural healthcare, but they don't have willing collaborators. We are willing collaborators because we need the help. And it's just a matter of finding the time in my schedule where I'm scheduling out 3 weeks out of my next available appointment, but I also know the impact of me going to Austin and testifying and being involved with Texas Tech El Paso and Texas Tech Permian Basin. Honestly, that's probably more impactful from a population health standpoint than my 18 patients a day that I attempt to see. And we have to have more time and more energy and coordinated effort reaching out and bringing folks here to help.
So it's almost.
I think recently, the federal government under the COVID part of that, I think it was $16 billion came from the federal government to Texas. And now I read today that they're planning on using some of those funds to enable a property tax refund for people who have homesteads and pay property taxes. I think that it's COVID relief. Hello, more of that should be that kind of thing should be directed to healthcare.
And while I was there, I met with State Representative Morales, and I threw out this idea of this Texas Center for Rural Health Education. And he was very much interested. He does not sit on the Public Health Committee, but he and his chief of staff at least talked to me for 30 minutes. And so I would encourage each of you, reach out to State Representative Morales' office and encourage that some of these ARPA funds be used for rural health care